the screen look? Looking okay? Let me get rid of that. Let me get rid of this. Okay, I'd like to welcome everyone to a special edition. We're going to call this the Coffee and Learn. It is no longer Lunch and Learn because we had technical difficulties earlier, but we're rolling now. One quick thing, in the invitation that you got, there was a big notice in red saying that this conference is being recorded for posterity, and that's another reason why we'd like for everyone to mute their mics. And if you're going to chat, you may want to keep your chatting appropriate. Thanks to everyone for your patience in all of this, and I want to especially thank Ann Kwan and Ms. Gilliam for Monica Gilliam for helping get all this going. We did have technical difficulties, but both of them are amazing. Okay, so without further ado, let's roll. We always do warm-ups. This is very important before we get to the more challenging cases. So let's start out with something easy. CT Challenge 101. Basic stuff here. Diagnosis. You can use the chat function if you want to use the chat to, let me know what you're thinking. Again, for a radiologist, even a non-neuroradiologist, a so-called body radiologist, I think this is not much of a challenge, but it's a nice case. Everybody looking at that? Okay, let's see. Let's see if we can get a hint. Hang on just a second. There we go. Here's a hint, circling the area of interest. And, yep, calcific atherosclerosis of vertebral arteries. And the question I would ask is, what's the difference between the two CT images on the left and on the right? Because they're at the identical levels. It's not a serial section. What's the difference? And again, it's an elementary answer. The left is brain windowed. The right is bone windowed. And yes, Dr. Trivedi just said windowed. Exactly correct. On whatever software platform that you have at your institution, it's usually super easy. You right-click, and you can switch on windowing between bone, brain, and additional settings used in body imaging. Bone windowed obviously is showing much more denser calcification. And you can see in this particular instance, we can still see the outlines of the two vertebral arteries. This is just an interesting incidental finding, if you will, that we frequently see on imaging studies. But sometimes the incidental findings are more interesting than whatever the primary finding, whatever the primary tumor is. The parallel in pathology is pathologists sometimes, they want to look at an H&E, might make a diagnosis, and then quit. As I like to say, they go brain dead, move on to the next case, and so it's meningioma, glioblastoma, pituitary adenoma. There's so much more to see than the primary diagnosis, both on images and in the histology. So I encourage you to be curious about that. Okay, Neuroimaging Challenge 101. Let's do an MRI. Again, I'm calling this 101 because, what I'm asking for really is a differential diagnosis. But remember, the rules of the differential diagnosis is whatever is statistically most likely is what you put first, what you list first, and it's statistically most likely based on the data that you have. So right now, the only piece of data that you have two pieces of data, two Venn diagram spheres. You have anatomic location and you have imaging characteristics, and you can see the location of this lesion. So without question, the number one thing, there's only one thing that should be at the top of your list, and that's colloid cyst. Now, there is always a differential. Have there been case reports of a solitary cysticercosis exactly in the foramen of Monroe? Yes, absolutely, and that's what makes it fun. There's always a differential, but common things are common, and so colloid cyst. All right, let's take a quick look at this. What made this so easy to come up with the number one entity on the differential diagnosis was the anatomic location. The anatomic location is in the third ventricle. So here's the third ventricle, and we've talked about this before. It's a very entity and anatomy-rich piece of real estate. So here you can see all of the anatomy of the surrounding structures of the third ventricle and what it overlaps. There's the foramen of Monroe, which I've highlighted in red. Now, for a massive massive third ventricle tumor, it's going to be very difficult to tell where it originated, although most of the time you can tell whether it's either anterior in general or posterior pineal region in general, but it can be difficult. For smaller lesions, they can be much more precisely localized, and I've given several areas here which are highly suggestive of what should be number one on your differential diagnosis. Now, the third ventricle, which is outlined in yellow, the hashed yellow, it overlaps anteriorly with the sellar and suprasellar region, so we would call that anterior ventral. Of course, anterior dorsal, there's only really one thing there. That's the foramen Monroe with some choroid plexus in it and colloid cyst number 1. And then posteriorly, the third ventricle overlaps with the pineal region. So posterior third ventricle pineal region, oftentimes it can be difficult to tell exactly where they originate from, but with smaller specimens, there are beautiful anatomic clues as to these lesions, and we will cover those throughout the course of this coming year. Actually, I guess I should say, since the academic year is going to end in a couple of months, we'll have to move quick to cover those, but we will do that. All right, here's the bottom line. These are the typical lesions which should be very high in your differential for tumors localized to specific areas of the third ventricle, and usually colloid cyst is pretty much all by itself there. So that is what you should see when you're seeing this beautiful mid-sagittal cut. How do you know it's almost exactly mid-sagittal? Because you can see the surface of the gyri here. We're not seeing cuts into the white matter anywhere, which means there's probably not a supratentorial mass of any significance on either side, because it would be pushing that part of the brain over. The second thing is the two smallest structures. The two smallest structures in the midline will be the cerebral aqueduct, and see how we can see it open, all right, from start to finish, and right here the infundibulum. It's a little bit pale at the bottom, but the pituitary stalk, the infundibulum, that is tiny, cerebral aqueduct is tiny. When you can see both of those, you know that this is a mid-sagittal cut, which means, yeah, okay. Okay, let's bump it up one. So I wanted to start off with something really easy. Let's bump it up to 201, Neuroimaging Challenge 201. And what I want is a differential diagnosis. All right, and it doesn't have to be rigorously in terms of what the statistically most likely. I just want a differential. Now, these are four different MD-ACC patients with the same diagnosis, and I'm simply giving you a spectrum of this entity, and I would just like for you to think, seeing what you're seeing here, what is your differential diagnosis? They're fairly large lesions. The one commonality that I would like to point out, I'm going to do it here with a cursor, is destruction, at least partial destruction and replacement of the clivus, of the bone in the region in the clivus here. I wanted to point that out because that's an important thing to note with respect to this entity. All right, what's your differential diagnosis? Anybody will pop up? Yes, Dr. Trivedi says chordoma. Absolutely. Dr. Cathcart, olfactory neuroblastoma, chordoma, pituitary adenoma. Okay, no, wait a minute. Wait a minute. Dr. Cathcart put pituitary adenoma. Are you kidding me? Destroying the clivus? And the answer says yes, absolutely. All four of these are pituitary adenomas destroying parts or all of the clivus. You know, listen, everyone in this room has seen pituitary adenomas that erode through the floor of the sella, erode through the walls of the sella into the cavernous sinuses. That's bone. They're going straight through bone. They can do it to the clivus too, these examples. All right, let's talk very quickly about definitions, pituitary adenoma size definitions. By definition, just by convention, microadenomas are less than 10 millimeters, less than a centimeter in diameter. Now, the sella itself is, it's fusiform, but it's roughly a centimeter, give or take. And so when an adenoma extends out of the sella in whatever direction, it's probably going to be a macro. Oftentimes, as you see in this scan, this is a T1 with contrast, and you can see the two arrows are identifying this microadenoma. It's confined to the sella, and the term that we frequently use here is hypo-enhancing. So the rest of the sella, the rest of the pituitary, which of course is outside the blood-brain barrier, and it enhances avidly. The adenoma oftentimes does not enhance as much as the adenoma. That's because it doesn't have the blood vessels, the acinar architecture. In fact, think about about it for a second. One of the ways as pathologists that we diagnose pituitary adenomas, but particularly microadenomas, is effacement of the acinar architecture. That's expansion of a clone which pushes to the side, compresses the blood vessels and all the reticulin that goes with it. So we do a reticulin stain. All right, that adenoma growing as a clone is not going to have the vascularity that the normal natural adenohypophysis does, and that's why it's hypoenhancing. Okay, again, as I just said, this is a nice example of a macroadenoma, just moderate size, but you can see it's clearly extending. If we draw a plane here where the diaphragm ocella would be, the dural duplication, you can see it's extending above. Nice macroadenoma. And now we get to the case in point, the topic in point we're talking about, which are giant adenomas, which are greater than 4 centimeters in any diameter. The original criteria were a little more complex than that, but it's pretty much simplified down to that. I don't think anyone would disagree that these are macroadenomas. Now, the main thing I wanted to point out here is, yes, pituitary adenomas, these big guys like this, can erode, destroy the clivus. And if you did not know that, now you do. And that's a wonderful thing, isn't it? Because that's an expansion of your knowledge base. Again, 4 examples just drawn from our our patient population here. Rare, but not that rare. Okay, I put that one in the middle. All right, you want to move on up to 401, like senior level. All right, let's try a neuroimaging challenge 401. All right, you ready? Chat in with your answers. Here we go. Oh, actually, sorry. I decided in retrospect, we're actually going to bump it up more than a 401. We're going to make it professorial, like a professor. All right, faculty level. All right, so faculty are eligible to play. All right, but this is why, everyone has to have something in this conference that they get right to feel good about themselves, because I'm all about that. But everyone also needs to be challenged, so we try to challenge the faculty as well. All right, ready? Here we go. Diagnosis. Okay, I'm going to go ahead and give you 45 minutes to examine the slide. All right, just kidding, not 45 minutes. All right, anybody want to chat in, want to text in with a diagnosis? See, this is why it's professorial. If it was some giant meningioma or pituitary adenoma, then it would be easy. All right, let you study it. Now, how you would get this, how could you even find it? It's a needle in a haystack. You would get it, yes, Dr. Caillet says schwannoma, Dr. Cathcart says optic pathway glioma. I would like to call out and compliment Dr. Susanna Caillet, one of our outstanding MD Anderson Cancer Center neuroradiologist, and let's go ahead. Oh, here's a hint. This is a hint. If Dr. Caillet hadn't gotten it right off the bat like that, this was the hint. This is the same patient. Oh, now we have multiple, there's lesions in a different place. In just a second, I'm going to ask you, okay, Michael Evans, yes, radiology fellow, NF2. Done and done. NF2, exactly. And what are we looking at here? What are we looking at here? Now, where is this located in the cord? Look, again, I'm going to point out, can everyone see the cerebral aqueduct right here? And look, here's the pituitary. We are midline. We are in the midline. Now, these could be really big, but they're looking like they're in the center of the cord. Now, we would want to see the axials, absolutely, to confirm that, but these are lesions. It looks like multiple, which is a little unusual, but not in NF2. What do you expect in the middle of the spinal cord in an NF2 patient? What do you expect these to be? And the answer is, of course, ependymoma. All right, let's go back here to this one. There are 2 intracanalicular vestibular schwannomas. The one on the right, which is over here, is a lot easier to see. Now, look, if you are being methodical about analyzing this, you might start up here and look at the orbits, and you look at the nasal sinuses, you move here, here's the middle temporal fossa, you're looking at that, you're looking at the sphenoid bone, could it be a hyperostotic meningioma, the sphenoid, very common. We're looking at the sellar region, we're moving back, here's the medulla, and you're always are going to look at the temporal bone. You're always going to look at the temporal bone. And look at this cut. This is an axial cut right through the medulla, right at the cerebellopontine angle, just right at it, where vestibular schwannomas would be, and you're seeing this abnormal enhancement on both sides. You like that? That was professorial level, wasn't it? But look at this. Susanna nailed it, all right? That's what we're talking about. All right, NF2, that's the overriding diagnosis, bilateral vestibular schwannomas. Would you have been happier with this? Okay, I tell you what, next time I will call this kindergarten level, and I will show you this exact slide, just in case anyone can't see them still. Okay, that's sarcasm, all right? And the sarcasm is just intended to reinforce it. Again, this is the smallest that you will see, but they are diagnosed, even unexpected, unilateral, sporadic, intracanalicular, all the time by expert neuroradiologists, those with a good eye. Okay, there we go. And of course, the diagnosis here, the ependymoma, maybe multiple ependymomas, but that's what it's going to be. Okay, that was a good. We're still warming up here. Let's do a neuroanatomy challenge. Don't you think that'd be a good idea? We'll call this. We'll make this one easy. Neuroanatomy challenge 101. This is what I want to know. This is the question. I'm not asking for a diagnosis. If you text back chatting with a diagnosis, you get an F, all right, like a 0. With which type of motor vehicle accident did this patient present? What type of, this is a very dramatic initial clinical presentation of this brain tumor patient. And it was with a motor vehicle accident. Anyone want to take a guess or chat, kind of anticipating playing the game? Darshan Trivedi, one of our outstanding Houston Methodist MD Anderson Cancer Center neuropathology fellows, says it was a T-bone accident, and Dr. Trivedi, exactly right. Komal Shah, absolutely. Dr. Shah, director of the fellowship program, T-bone. Yes, it was a T-bone. Now listen, for anyone listening to this conference, and you're wondering how could these people know it's a T-bone, because how often do we ask which type? I mean, like head on or ran into. No, that's not. Which type is most characteristic? So what does the T-bone mean? Well, here we go. This is the patient, and hopefully what you're seeing here is a very nice pituitary macroadenoma. Do you see how I prepared you for this case? All right, with the challenge. And what is the structure right at the top that's being bowed, right? Make it like a bow and arrow. That is the optic chiasm, all right? And the T-bone is the axis. So look at this. There's a T. Everyone recognizes that. I'm just going to complete the road. Here's traffic going this way. Here's traffic going this way. Of course, both sides. The patient's car, let's imagine, going this way. Here comes the other car. Bam, that's a T-bone, all right? That's what that's called. The patient is hit from the side. Why? Why was the patient hit from the side? Because the optic chiasm, right, is being compressed, ischemic, axon loss, fiber dropout. So the function of the fibers in the chiasm, all right, not the tracts and nerves per se, but the chiasm, are being compromised, all right? All right, here's a hypothetical. You're the senior resident on your service, neuropathology or pathology, neuropathology fellow, or neurology resident, neurosurgery, neuro-oncology. You're the senior resident on the service. Patient presents following a motor vehicle accident with bitemporal hemianopsia, secondary pituitary macroadenoma, like the patient we're talking about. Could you grab a piece of paper and sketch out a diagram of the nasal and temporal retinae, optic nerves, optic chiasm, and optic tracts, and show the trainee, show the medical student with amazing simplicity so that they will never forget it because they will understand it, what's going on? If you can't do that, right now, then you're not yet ready to be a role model for even the greenest of the green medical students in a neuro specialty. Now, if you're a body imager or if you're a general surgical pathologist, I will cut you a break, but not for the neuro people. Okay. Get to work, learn it. It's not rocket science. In fact, it's beautiful in its simplicity. All right, I learned it back way back when I was a graduate student in neurology. I've never forgotten it. Okay, in fact, here is a diagram that I did this very day, and honest to goodness, this took me, I should have timed it. I think it was 30 seconds. All right, and what I'm illustrating here, this would be temporal retina, nasal retina, temporal retina. Here we go, the optic nerves. Here goes the chiasm crossing, the optic tracts going back. Here's the pituitary adenoma, which is pressing on the chiasm. Now, follow the fibers that cross. It's only the nasal retina, all right, axons that cross in the chiasm. The temporal retina, all right, stay outside. They're on the far part, so they do not get compressed initially. The nasal retina, you look at this, perceive the peripheral fields, all right, that lateral vision. The central vision is preserved. It's not touched. Hence, the patients with pituitary macroadenomas with bowing and compromise of the chiasm develop bitemporal hemianopsia. That is, the temporal visual fields are lost. The layman term would be tunnel vision. That's what they see, tunnel vision. They never saw the car coming right from the stop sign or whatever, from the right, from the left, and bam, that's how it happens. It is not unusual. Okay, this is a happy conference, okay? I was just kidding about being not being a role model. I'm sure you're all excellent role models in many other ways. Okay, here we go. Next case. All right, let's do a neuropathology challenge. We're doing all this, kind of imaging, right? Let's do a neuropathology. We'll make it 101. We'll make it easy. All right? What's your diagnosis? What is the neuropathologic diagnosis in this case? It actually, you might consider it, in some instances, it's really a neuroanatomic variant. It does not have to be pathologic. It just frequently, with the symptomatic patients, it is pathologic because it has a specific etiology. But it can be just, and to a certain extent, it's just a normal anatomic variation. Anybody want to chat in? Okay, I called it a 101. No pressure. Okay, well, here's a hint. The hint, yes, Dr. Cathcart got that in. Basilar dolichoectasia. Okay, this is dextro. Okay, did you just say dolichoectasia? Was the dextro in there, Dr. Cathcart? If the dextro, meaning it's going to the right, wasn't in there, then I'm only going to give you a 50. All right, so that's an F, but you can be very proud of that. It's a really high F, okay? Dextro, dolichoectasia, and levo, left, dolichoectasia. This one's a dextro, but look, it's curving, all right, to the right. This is the patient's right side of the basilar artery. Everyone seeing this? Here's the two vertebral arteries. Here it's curving. All right, well, what's the significance of that? Well, there it is. There's the etymology, dextro, dolichoectasia. All right, well, what was this patient's neurologic disease? This patient actually did have a neurologic disease that was treated, and the disease, the neurologic disease, was caused by this, exactly what we're seeing. It was actually atherosclerotic induced dextrodolichoectasia. Anybody want to guess? You want to chat an answer here? Is what condition did the patient present with? All right, and Dr. Trivedi says lateral medullary syndrome. Okay, that's good. That could be vascular compromise. It's not due to the vessels, what it's doing to the vessels. Yeah, there you go. Okay, I see several right there. Yes, trigeminal neuralgia. Absolutely. Pressing on the fifth nerve. Excellent. Very good. Here's just one paper from the literature, 2017, Neurosurgical Review. Microvascular decompression is effective therapy for trigeminal neuralgia due to dolichoectatic basilar artery compression. Case reports review the literature. These are just cool to see. Again, most of the time in our patient population, this is an incidental finding, right? And it's not symptomatic. It's more of a variant, but it's good to know about. Okay, and this is just this review paper from 2017. Look at table number 1. All of these different publications talking about trigeminal neuralgia due to dolichoectatic vertebrobasilar arteries. That's a lot of cases. So this is not a rare thing. This is not a zebra that I'm presenting. Just wanted to point that out. Okay, are we getting warmer? Everybody feeling warmer? Good. Okay, let's take a quick decompression break. We're going to take a break because it's been fairly intense. An exercise in thinking outside the box. I want you to switch gears here. Thinking outside the box, it means something's coming from left field, right? Instead of the rote stuff we do, instead of the pattern recognition that is so helpful to us, but it always won't get the job done. Initial clinical presentation MR imaging studies of a patient with a 3-week history of increasingly severe headache, nausea and vomiting, and a 6-centimeter mass in the right frontal lobe. All right, what is the patient's disease? What disease does the patient have? I'm giving you all of the information you need. There's no lesion here, by the way, in the brain. Can you see? I mean, look at this coronal T2. Seriously, that's what I'm going to show you. But if you use deductive reasoning, if you analyze all the data, if you get granular and you're able to see the forest, not just the trees, then you can pick this out. What's missing? You know, sometimes, listen, sometimes it's what's not there that's the key, not what is there. We always want to see what is there, you know, the giant thing that pops, that grabs our attention. Sometimes that's not what's important, what's missing. Now look, this is initial. Did you see that? Initial clinical presentation. This is not the 50th surveillance imaging scan. It's initial. Are these the sequences that are run routinely for initial presentation? of a patient with headache when they're going to look at the brain and figure it out. Something's missing. What is missing? And why? What does it tell you about the patient? Now, it's not absolute. I'm asking for a differential diagnosis, I guess, of what's missing, but there's one thing that is absolutely the most common. Which sequence is missing? Oh, yeah, what disease does the patient have? Anybody? Nobody wants to play? Okay, where's the T1 with contrast? Yes, thank you. Susanna Collier, again, kidney disease. Of course, it's the one pretty much absolute contraindication is severe kidney disease. No, in general, this is just for those, I mean, there's many people who may not know, we usually, I mean, I say we, yeah, it's always best to have T1 pre-contrast and T1 post-contrast. Now, sometimes that can be omitted under different situations, et cetera, but as an initial workup, unless there is a contraindication, that's going to be performed. It's not here, and the answer is, yeah, this patient had severe chronic renal disease. This is a patient. This is a recent MD Anderson patient, and I just simply made that observation. You know what I do? Look, here's the thing of it. If I want to be super fast, I'm running behind, there's 10 patients on the OR schedule. Actually, there's usually 0 to 1 patient on the OR schedule these days. But let's say there's 10 patients on the schedule. I'm running behind. I want to have a super quick look at the imaging. I pull up the T1 with contrast and the T2 flare. Pull those up axial side by side. It gives me a quick look. When I cannot find the T1 with contrast, especially in the clinical setting of initial presentation, that's setting off big alarms, and I'm going to be looking to see why, what's the explanation. In this particular patient, that is exactly the explanation. You like that? That was kind of fun, outside the box. Okay, here we go. That was so much fun. I think we need to do another one. Everybody up for thinking outside the box number 2? Now, I did address this fairly recently, so some people are going to pick up on this, but that's okay. I've improved some of the slides, as we all do. All right, the brain, and I'm going to talk about fungi. All right, fungus and the brain. Ready? I want to know the disease. Which fungus is this? Which fungus is it? All right? This is a second patient. This is patient number 1. They have the same fungus. And I'm going to show you one more. I have 3. I have 3 in my collection. 3 different patients. Which fungus is it? Darshan Trivedi said brain herniation. Be more specific. Yes, be specific. What fungus is it? Fungus herniation? What is the name? Darshan is actually correct. I'm giving her, it's fungus cerebri. The name is fungus. Yeah, it's fungus cerebri. Fungus cerebri is herniation of brain through the protective coverings, okay? And it can be transcranial herniation, and it can be due to any number of things. All 3 patients that I just showed you were glioblastoma, which were herniating through a craniotomy defect, in which the plate was the calvaire was not replaced. So those are all 3. Those are 3 examples. Okay, this is just a this is history, I guess, if you will. Let's go back to 1871. Transactions of the American Ophthalmologic Society. Gunshot wound to the brain followed by fungus cerebri, hemianopsia. Here's military medicine, 1956. 2 very famous neuropathologists, Courville and Webb Haymaker. Fungus cerebri is a complication of missile wounds in the brain. This was Civil War. Fungus cerebri, brain fungus. This is pushing it a little bit. They actually translated it for us, a rare complication of mastoidectomy. They're not talking about fungal infection. They're talking about herniation. It turns out that a lot of the recent examples of this transcranial herniation are in mastoidectomy patients. And so relevant to the head and neck world. And then finally, look at this, 2019, traumatic cerebral fungus. And they're talking about herniation. They're not talking about a secondary fungal infection from an institution in Northeast India. But the term is not absolutely specific. For example, look at this paper, meningoencephalocele, also known as fungus cerebri. So I guess we could broaden it to include meningoencephalocele. Anyway, that was a historical lesson. I hope you found that refreshing, because now it's time to move on to our patients. All right, patient number 1. Hope everyone's warmed up. 66-year-old female. All right, here are the panels. Upper left, T1. Upper right, CSF T2. Lower left, T1 with contrast. You see the vessels. Lower right, T2, fluid, all right, attenuation, all right, flare. fluid attenuation, inversion, recovery. And there they are labeled for those not familiar. What's your differential diagnosis? What's a differential? Two things are in your differential. One comes before the other. All right, Dr. Harb, Zainab Harb, glioblastoma, Michael Evans, glioblastoma. All right, number 2 on the list from Dr. Harb, metastasis. That are absolutely correct. And Sahara Cathcart, glioblastoma, IDH wild type. I like that, Dr. Cathcart. How specific is that? Because the patient's 66, statistically 85% of glioblastomas. Now, question, listen. If all you have, I think, is this on the left, if all you had was a T1 post, then it would be metastasis, which is an order of magnitude more common than glioblastoma. All right, and just statistically, in glioblastoma number 1, metastasis number 1, glioblastoma. But we have the T2 flare. Look what is happening here in the non-enhancing portion. Non-enhancing portion here and back here. Look at the blurring of the gray-white. Look here. Look at that gyrus. That's blurring of the gray-white. Corresponds to this area right here. That is diffuse glioma. Diffuse glioma until proven otherwise. This was, in fact, glioblastoma IDH wild type. Here's the histology, all right, of the case. So we're moving on now. What's the morphologic subtype? Anybody want to play on this one? What's the morphologic subtype? Dr. Trivedi, small cell. Yes, absolutely. Dr. Cathcart, small cell, absolutely. There are 22 morphologic histologic patterns seen on H&E, just with H&E, 22. Look at these. The last 2 additions to the list, subependymal giant cell astrocytoma-like, SIGA-like, and FGFR-TAC fusion glioma have very characteristic H&E morphology, not pathognomonic, but highly characteristic that make us suspicious, like red flags, all right, to check them out. All right, so morphologic subtype, here's the list. There it is, all right, small cell. I put it right after giant cell, small cell. Let's look at it, look, higher power. What is always, listen, for classic small cell glioblastoma, there is always another entity, primary glioma, in the differential diagnosis, and what is that entity? AO, anaplastic oligodendroglioma. Can you see how monotonous these cells are relatively, and they can have halos? They're usually more pleomorphic than oligo would be, and that's a clue, but oftentimes they're very close. Here you can see the vascular proliferation in the center, which is going to make it glioblastoma. Here's some necrosis with surrounding pseudopalisading, which is just denser cell types. And then, okay, here is an intravascular fibrin thrombus. Here's a fibrin thrombus. Here's a fibrin thrombus. That's making it IDH wild type that Dr. Cathcart had already surmised, putting it number 1 on the list because statistically 85% will be that rather than secondary. Here's the IDH1 or 132H. You can see just hematoxylin staining. It's stone cold negative for mutant proteins. Therefore, the W 2016 says we do not have to perform PCR or NGS or methylation profiling. We can call this glioblastoma IDH wild type because the patient is older than 54 years of age. Look at the EGFR behaving as expected. You can see the blood vessels, the vascular proliferation, sort of painted in negative relief. It's a good way to see the vascular proliferation, actually, in cases which do have the EGFR overexpression. Look at this beautiful membranous pattern as well as cytoplasmic. This is 4+ overexpression of EGFR. It does not have to be due to amplification, but frequently it is, and that's what we're really interested in because EGFR amplification is a signature which primarily is overwhelmingly associated with glioblastoma. All right, here's the actual NGS. Now, this is MD Anderson NGS. Next generation sequencing, and let me just point something out very quickly. I've done this before, but for those who may be new, notice that BRAF is underlined, PDGFRA is underlined. The genes that are underlined are the genes that were requested by the neuro-oncologist. Usually it's a neuro-oncologist or pediatric neuro-oncologist. Any gene that's circled in red has an alteration. It's visual, it's pattern recognition, it's unambiguous to the primary care physician. You don't have to hunt down a list to which one, out of all of the negative, and one is positive and it's lost. You don't have to do that. It's screaming. Now note, what the circles say is these genes are altered. It doesn't mean mutated per se. It could be amplification. It could be insertions. Could be deletions, the indels, etc. Right? You have to look at the second section immediately below this to see the details. All right, so I'm going to ask you, the TERT was a TERT promoter mutation, minus 124, minus 146, the two canonicals. The minus sign means it's in the promoter, not the coding exon. Let's talk about the differential diagnosis for EGFR alteration. So just based on knowing that there's an EGFR alteration, what are the different possibilities? Well, we've already mentioned amplification, all right? And in fact, look at this. Yes, right, Dr. Hard says EGFR amplification, and also added V3, and about approximately gain of 7, Dr. Cathcart, gain of 7 from EV3 amplification, absolutely. Approximately half of EGFR amplified glioblastomas, is 40%, will show EGFR V3, so that's about 20% of overall. We're going to look at it in just a second. Okay, look at this. This is what was immediately below the graph, the visual presentation I just showed you. There is an EGFR amplification. As you can see, the cytoband, it is chromosome 7p11.2. All right, here we go. Guess what? Not only was there amplification, there was also a fusion, because we frequently, the neuro-oncologists here at MD Anderson will order Oncomine, which is our NGS platform, for both mutations and copy number, which come together, all of that data analyzed, and fusions separately. There's also a fusion. Now, here's the way the fusions are reported out. Usually, with a fusion, obviously, it's two genes. So you have the upstream gene and the downstream gene, all right? And then the fusion details, exactly what's going on. Let's look at some examples of upstream, downstream fusion details. What are some other examples of clinically relevant in oncologic neuropathology? Obviously, if you're a sarcoma, soft tissue sarcoma, I mean, fusions are like huge, and that's a wonderful world. There, but we have a few of our own in neuro-oncology. Let's look at a few. NAD2-STAT6 fusion in solitary fibrous tumor. Ewing sarcoma R1 Krebs family fusion in myxoid mesenchymal tumor, intracranial CNS myxoid mesenchymal tumor, KIA1549B-RAF fusion, pilocytic astrocytoma, QKI-MYD fusion in angiocentric glioma, FGFR TAC fusion in diffuse glioma, and extraventricular neurocytoma also shows a high incidence of recurrent, which means commonly occurring, FGFR TAC fusion. Okay, well, let's look at our case. Guess what? But the upstream gene is EGFR. The downstream gene is also EGFR. Well, what's going on? It tells you right here in the fusion details. It is an EGFR fusion. Well, how do you fuse a gene to itself? Well, you have to delete something in the middle. And so what the fusion is between exon 1 and exon 8. So exons 2 through exon 7 are deleted, and that's what this DEL says. It's a deletion. So this is an intragenic deletion of exons 2 through 7 with fusion of exon 1 to exon 8. What do we usually call that? We usually don't give it this name right here. That is really cumbersome. We have a different name for it. I want to see the chat light up. I want to see the chat line light up with what we call this. This is how, listen, this is how we detect this very important genetic alteration in glioblastoma. We detect it through the fusion panel. Yes, Dr. Cathcart was first in with EGFR V3, and there's Darshan Trivedi V3, absolutely. Again, these are both of our neuropathology fellows. Good job. Excellent job. Yeah, what do we call that? We call it EGFR V3. Yes, let's take a quick look at it. Here's a nice 2018 Oncogene paper, epidermal growth factor receptor, EGFR V3 and glioblastoma, signaling pathway targeted therapies. All right, here shows the native EGFR wild type on the left. Here's EGFR V3. This is what's deleted, and what they're showing you is deletion of amino acids. We say amino acids 6 through 273, and those, of course, comprise exons 2 through 7. Okay, so let's take a look. Let's take a look at EGFR alterations in glioblastoma. Okay, first, and these are approximate. Everything's approximate, depends on the series, but approximately 60%, all right, of IDH wild-type glioblastomas will have an EGFR alteration of some type. It's one of the most common alterations in glioblastoma. All right, amplification is the single most common EGFR, and it's virtually always associated with EGFR overexpression, and that's about 40% of all IDH wild-type glioblastomas will have amplification. So it's not the majority, but it's a big plurality, if you will. All right, deletions. Yes, deletions also occur. EGFR V1, which is an N-terminal deletion, V2, deletion of exons 14 to 15. 15. V3, exons 2 through 7, that's what we just looked at. That's going to be about 20%. So V3, this is why we don't see it all the time. It's only approximately 20%. Still, that's a big chunk. Here's V4, which is exons 25 to 27, and finally V5, 25 to 28. Okay. Again, as we mentioned, approximately half of glioblastomas that show EGFR high level, not just polysomy low level, but high level amplification, frequently double minutes, will show. About half of those will show EGFR V3, which is very important because it's oncogenic. V3, constitutively active epidermal growth factor production. All right, point mutations, absolutely. EGFR point mutations, well characterized, are seen in glioblastoma. Here are a few of the most common: R108K, R289V, or D, or T, G5, and there's others. About 25%, about a quarter of glioblastomas have a point mutation. All right, so again, how did we get to this? Let's go back to the beginning. This is what you will see. And the initial report says, this is a glioblastoma. There's an EGFR alteration. What is your differential diagnosis? This is what you should think of, right? I have put it all together, all right, for you from that, summarized it, simplified it from that one paper, right? But this is the level. Listen. It's good to know that glioblastomas frequently show EGFR alteration, that the glioblastomas frequently show EGFR overexpression, that glioblastomas frequently show EGFR amplification and show V3, all right, that specific. It's better to know this, to know the spectrum, the range, right? And so if you get back, let's say you get a report back and it just says EGFR altered, that's not good enough. Right, you need to look at the details, the granularity, right? Okay, I'm urging you to not make assumptions, to be detail-oriented, to be critical. Critical means skeptical, right? Yeah, okay, good. That segues beautifully into a little piece of trivia, historical trivia. Back in the day, what abbreviation for a commercially available anti-EGFR V3 antibody did one immunohistochemistry laboratory use? They use an abbreviation because it's shortened by a few characters, the name, so they could get all the information on the label of the slides, right? Because you have to get the patient's name, you want the medical record number, you need to have the surgical accession number, usually you have the hospital and the name of the antibody, and they found out an ingenious way, perhaps, to shorten the name. What do you think it was? What was the abbreviation? This is thinking outside the box. How would you shorten it? Okay, time's up. Thank you for playing. EGFR 8. Do you like that? Okay, so that's a problem with not having actually everyone in the room. I don't know if anyone's laughing or not, but the bottom line, it's confusion. It was actually confusion of V3 with V3. All V3s are not created equal, all right? The lowercase V3, that's variant 3. The big V, which is a 5, 1, 2, 3, that's the Roman numeral for 8, all right? So, yeah, for a while, the EGFR, when the antibody was available, we ran it all the time. The label said EGFR 8. You like that? Yeah. It's either brilliant or stupid. It just depends on your perspective. I'm going to say it was brilliant. All right, but this is just one more reason why the WHO CNS classification will likely abandon Roman numerals in favor of Arabic numerals for the WHO 5E 2020 coming up later this year. All right, now let's look at the morphology of an oncologic neuropathology report at a tertiary care institution, which means subspecialists. Subspecialists. The subspecialists are the people that really know what they're doing, because that's all they do. They live it and breathe it, right? Okay, this is the report in whole. Notice, is anyone having trouble finding the diagnosis in this MD Anderson Cancer Center report? It's screaming, the big bold thing. That's the bottom line. Let's go through it very quickly. Brain, all right, so side, the exact location as good as we can tell, not from what is written on the label from the OR most of the time, but from the preoperative compared to postoperative neuroimaging studies, and the tissue often tells us what goes here. I want my reports accurate. Then the procedure, craniotomy and a resection was performed. Then there's the diagnosis, all the important stuff. Then we have how is this diagnosis made? These are the critical features. IDH1 by immunohistochemistry, right? It's negative for the protein expression. et cetera, all the important stuff there. All right, then in a comment, I always start off the first paragraph, H&E, to show all what's important stuff. You can get a long way with H&E. Look, small cell morphologic subtype with elevated mitotic active vascular relation necrosis, including palisading. That's how we got to histologic glioblastoma by the old criteria. Molecular signature determination studies by surrogate immunophenotyping, results shown there. Sometimes we will elaborate here if it's more complex. And then finally, always, virtually always, the last paragraph, especially initial diagnosis, diagnosis of glioblastoma wild type W34 is congruent with multiple preoperative MR imaging studies which showed an irregular, REM-enhancing centrally necrotic mass, right superior temporal gyrus, and on preoperative ABTI, advanced brain tumor protocol studies. Okay, wait, this is like hold the phone. All right, hold the phone for just a second. We have to run through this quickly, okay? And I see I have 1 minute to go, so I'll just finish this series, okay? And we'll call it a day. I had one more patient, but that patient can wait for that can wait for next week. ABTI, advanced brain tumor imaging. We used to have a fantastic conference every Wednesday at noon that met. I think it's up to me to carry on the tradition. ABTI, 3 measures of blood perfusion and MRS, magnetic resonance spectroscopy. Here are the 3 measures of blood perfusion. ASL, arterial spin labeled, measure of blood flow. DSC, dynamic susceptibility contrast, relative blood volume. So blood flow, blood volume, and finally DCE, sometimes loosely called permeability. It's actually K-trans. This is gadolinium transfer from blood into tissue. So all measures, 3 different measures of blood flow, which is critical in many brain tumors and in differentiating them from a treatment effect. And then the second component, proton MR spectroscopy or MR spectroscopy or just MRS, where we can measure non-invasively choline, creatine, NAA, lipids, lactate. Very quickly, choline, that's membranes. That's cell membrane. That's going to be cell density. So small round blue cell tumors, that is high nucleus cytoplasmic ratio, you're going to have a lot of membrane. Creatine, energy metabolism, NAA, neurons. Think neurons. All right, neurons are all dead. They're gone. NAA is going to drop like a rock. Densely cellular tumor, more cellular than normal brain, choline is going to skyrocket. Lipids and lactate, measures of ischemia, necrosis, you're going to get a good peak here. Okay, the way we map out MRS, these important is basically up by parts per million. Up is good, normal, down is bad. This is Hunter's angle, 45-degree angle. Here we can see, here's choline, creatine, NAA. All right, look at the slope. All right, up, this is normal brain. You can see where the voxel is just to the side of the lesion. Here's the voxel right in the lesion. Look at the elevated choline. NAA is down, and as a bonus, there's actually a lipid lactate peak right here, about 1.3 ppm. This is always the way that these metabolites are mapped out for. Again, there's pattern recognition going here. Pattern recognition, just like looking at a CT or an MRI scan or an H&E slide or the graphic distribution of oncomine alterations. Okay, this is a lipid lactate peak at 1.3. We need to look very quickly here at a time to excitation 144 milliseconds. Only the lactate is separated from the lipid, and it's inverted, it's reversed, and that's how we can tell if there really is lactate. So let's just very quickly look at the effect of TE on lactate peak. So long TE, we'll call it 288 milliseconds, intermediate 144, and short 35 milliseconds. See, I'm giving full credit from Radiopedia here to Dr. Gellard. Here we go. All right, long TE, here's the typical upward going lactate double peak. So you see the double peak? Jason Johnson, Dr. Jason Johnson, one of our stellar neuroradiologists who co-runs the ABTI conference, like to call this, I think, the fangs, like vampire fangs, or like a snake, the snake fangs, which is actually a tongue. Those aren't fangs. Yeah, I know that. Here we go. 144, this is the inversion, all right, inverted lactate peak, still with the fangs, or double peak, and then 135 short, upward going again. All right, so when we see this, this spectrum, we know there's a big lactate peak. It's probably going to correlate, certainly with ischemia, probably necrosis. All right, can we please get back to the report? You guys are trying to distract me, right, with the ABTI. I just wanted to provide that as an introduction. We will be reviewing for real cases, all right, as this conference series go on, where we actually include that data in our analysis so everyone has the background on it now. All right, so ABTI, look, that's where we left off, and then I just described it. The enhancing rim and nodular components have elevated flow by perfusion, elevated K-trans on DCE, and elevated volume on DSC. All right, with MRS showing marked elevated choline to creatine ratio and a lipid lactate peak in the necrotic area. And I will always acknowledge the expert C radiology report accession. I redacted that by Dr. Vinod Vince Kumar. This is Vince Kumar, the other co-runner along with Dr. Jason Johnson with our ABTI conference. And Dr. Kumar truly is a national, international expert in brain mapping and pathways, and will be hosting a conference on this functional MRI and then this type thing, which is a very prestigious honor, and we congratulate Dr. Kumar on that. All right, here's Dr. Kumar in the center here, the ABTI. This was, I think, taken about 2 years ago. Dr. Sawaya, the former chair, attends the conference regularly. That shows its importance. And then here's Dr. Jason Johnson, and this is the nice picture of Dr. Johnson. There we go. All right, we give credit where credit is due. Patient number 2, you know what? I tell you what, I show that it's 5:04, and I want to thank everyone for sticking with me this long. Thank you for attending the conference. We will be doing this again next week. I hope to make it, along with the help of Ms. Gilliam and Dr. Kwan, go at noon. But until then, I think I'll just say goodbye. Thanks for tuning in, and I hope you learned something. Much appreciated.